Thank you very much, Prof. Yeah, that's exactly right. This was a case that we saw a couple of weeks ago, and really highlighted a bit of a gap in my knowledge, and took a few learning points away from, so I thought it would be very good to share. My name's Tom. I'm currently on acute medicine at Charing Cross, and we saw this patient on the post-take ward round, I think. Any questions, please feel free just to either stick your hand up, put them in the chat. I haven't got access to the chat at the moment, so someone may have to keep an eye on that for me.
I'll do that. I'll ask. I might interrupt you if that's all right.
That's absolutely fine. And there'll be some time for questions at the end. It'll take about 20 minutes or so. But yeah, feel free to interrupt. So this was basically an acute case that demonstrates when to start dialysis. So we'll start off. The case is Mr. R. He was a 54-year-old gentleman and actually attended Western Eye Hospital initially with a painful red left eye. He's got a background of CKD. He had a left radical nephrectomy for a renal cell carcinoma in 2016 and hypertension. In terms of medication that he was on, he's on some antihypertensives there. He's on a statin, allopurinol, vitamin D, and some EPO. And at Western Eye Hospital was actually clinically diagnosed with a viral conjunctivitis. However, they were slightly concerned by some of their findings on fundoscopy, where they noticed some Roth spots and retinal hemorrhages. So discussed with the MedReg at Charing Cross and brought them across here because they were concerned about endocarditis. But actually, Mr. R at the time was clinically well and reported no other symptoms. So on examination, Mr. R had no peripheral stigmata of endocarditis. He had normal heart sounds with no murmur, had a small bit of peripheral edema, good air entry throughout his chest with vesicular breath sounds. Obs were all normal, blood pressure was okay, and was saturating well on room air. And he had an AVF present in his left forearm, which was a pertinent real finding on examination. And just to clarify what I mean by AVF, I basically mean arterial venous fistula. And that's basically anastomosis between an artery and a vein, which basically allows the vein to arterialize, meaning it becomes bigger, the walls become thicker, and that basically allows that to be needled multiple times for access for dialysis. And Mr. R in this case actually had a left radial cephalic fistula, and that had a strong palpable thrill and a large Bruin auscultation, looked well sort of set in and looked ready to be used basically. Bloods wise, he had normal inflammatory markers, he had a normocytic anemia, he had a raised creatinine on a baseline of a raised creatinine of about 787, raised urea of 32 on a baseline of about 27, with an EGFR of 5. His electrolytes were normal, his inflammatory markers were normal, he was not acidotic and had a slightly raised phosphate. So at the time, the plan for the medical team was to be admitted for an echo, some serial blood cultures, and for a renal review.
Yeah, is there any questions at this point with those remarkable results? No, I guess not. Okay.
Tom, can I ask something?
Of course.
What did you tell us, the audience, something about what this guy actually looked like? Was he a big fellow? Was he a small?
So I think the best way to describe him as he was a bit of a rugby player. He was probably a second row. He was a big gentleman, probably had quite a lot of muscle mass, but also there was maybe some extra weight there as well. So he was a very large gentleman.
And you've just been asked the potassium.
Yeah, it's there on that road.
The potassium's 5.1. And that was on formal lab bloods, and the VBG was very similar.
And Tom, sorry, Jeremy Levy here, one of the other consultants. Are you going to say anything else about his background? Because actually, it turns out I've now realised I know this man from 3 previous years of care at Chelsea and Westminster. But if you are, I won't mention anything now, but otherwise pertinent to that question.
So I'm actually not going to mention his other personal background. I'd sort of left that to one side.
No, sure. So the only thing I'll say, no, that's fine, and that's very sensible. Shall I, so in terms of that last question where somebody asked it, I had been trying to persuade this man to start dialysis for about a year, and he'd been refusing.
Fine. Okay. He has got other past medical history in the past, and I haven't included that because it would slightly muddy the waters.
No, that's fine. That's fine. It was just that's why he's
purely-
got a functioning fistula. He's been very resistant to starting dialysis.
So what we'll do actually then is sort of park Mr. R's case here for the moment and just have a look at some of the alarming things, or maybe more concerning things for some of us acute medics. Is that creatinine, the urea, and the EGFR. And we'll just take a look at his EGFR against time. So as we can see, there's been a steady decline in this gentleman's EGFR from about 2017, where he first attended renal at Charing Cross of about 30, and there's been a steady decline of about 4 to 5 loss of his EGFR a year till about 20 or end of 2021, start of 2022. As you can see, this chap is right on the verge of when we would consider starting dialysis, and we were right at that point. And as Prof. Mirren says, quite flying close to the wind in terms of when do we start this gentleman on dialysis, and how do we start this gentleman on dialysis? And that sort of leads me on to what we're going to talk a bit more about today. And that is, what are the factors that affect the timing of commencing renal replacement therapy in a patient with CKD who's got a progressive decline in their EGFR? And not really going to talk about the role of hemofiltration in acute kidney injury. We're going to leave that there. And in this situation, it was not indicated, and the indications are slightly different. So we're just going to hold that one there for the moment. So just a bit more background about dialysis in the UK. There are a lot of patients receiving renal replacement therapy in the UK. This is data taken from the end of 2019 and looks at the whole population of people receiving dialysis in the UK. So there's about 68,000 people. And they receive dialysis through various different methods. Sort of 56.8% of these people are receiving their renal replacement therapy through a transplant. And that's that large redder slice of that pie chart there. The next largest proportion is in-centre hemodialysis, so 35.8%. And that comprises of both hospital hemodialysis, so 14.2%, and also satellite hemodialysis, meaning they receive their dialysis in a satellite renal unit that may not be attached to sort of a hospital with inpatient beds. People then also receive peritoneal dialysis, so 5.4% of the whole population of people receiving dialysis. And that's obviously split into our continuous ambulatory PD, but also automated PD. And you can see these by the smaller segments of this pie chart down here. And last, not least, is home hemodialysis. So about 2% of people are receiving home hemodialysis. And this is data from the end of 2019. And actually, these numbers have changed throughout the years. When dialysis was first becoming more, well, first introduced as a treatment in sort of the 70s and 80s, there was a much greater proportion of patients who received home hemodialysis. So about a third of all patients receiving dialysis received home hemodialysis. And actually Charing Cross was one of the biggest centres providing this, one of the pioneering centres, and sort of had patients all the way from Kent to Cornwall who would travel all that way for their sort of 3 monthly reviews. But obviously, as the numbers of patients receiving dialysis increased, sort of the logistical challenge of delivering home hemodialysis also increased. So actually, therefore, the proportion of people receiving home hemodialysis has fallen. And that's also through there are other options and things available now in terms of peritoneal dialysis. So that's one of the reasons why these numbers are changing. And one thing that I was a bit surprised about was actually the most common identifiable primary renal disease in this cohort of patients, so if you looked at all of these patients, was actually GN, so about 20%, but that is rapidly changing. So that's this whole population. If we now more to look at the people who were initiated on dialysis, so looking at data from the 1st of January 2019 to the 31st of December 2019, these are the patients who started dialysis. So about 8,000 people were started on dialysis in that time frame. The median age was about 64 years. 63.5% of people receiving renal replacement therapy were male, and diabetes is the most common identifiable primary renal disease in this cohort. Hence why in the future, if we look at total numbers, it will soon be the most common reason as to why people receive dialysis. A few interesting bits from this data is actually why we are seeing more men receiving dialysis. Men are not more likely to get kidney disease than women, but they tend to progress quicker than women. So actually, if a man gets kidney disease, they are far more likely to progress quicker than women, and we're not entirely sure why that's the case. There's been some sort of speculation around this, and it's really thoughts to do with how activation of the renin-angiotensin system differs between sexes. But there's no real research that sort of backs that up. And that's looking at this population that started dialysis this year. Not this year, in 2019, sorry. So how did these people start? So out of these 8,000 people, about 71% start on in-center hemodialysis, so hospital hemodialysis or satellite hemodialysis. 20% started peritoneal dialysis, and about 0.5% were started on home hemodialysis. And 8.3% started with a transplant. So numbers are slightly changing. And if we take transplant away there actually, and we look at the patients who started on either hemodialysis or peritoneal dialysis, and about 20% of these patients are actually preemptively listed on the transplant list as awaiting organs and things. So what does the ideal look like? And this is probably the most important slide. What is the best way to start dialysis? And I guess the answer to that is fairly straightforward. It's probably, well, it is a transplant, and that was 8.3% in 2019. And that's because it's got clear benefits in terms of quality of life, but also mortality for these patients. The next best option would probably be to start renal replacement therapy in a modality which suits you the best, which we could talk about a little bit more about shortly, but start on the transplant list. So that's about 20% of patients. And ideally, if this can be a home therapy, then that's again, positive for the patient. But we have sort of not really thought about a group of patients here, and actually the ideal for some patients may not to be have renal replacement therapy at all. They may want to focus more on quality of life rather than extending it. So you may opt for something called supportive care. And this is an important group to be considering as well. And in supportive care, symptoms and biochemistry are sort of managed medically, with focus, as I said, being really on increasing quality of life rather than sort of extending it. But the most important thing about starting dialysis, no matter what mode or method that you start on, is that it's done in a controlled, planned manner. It's not a medical emergency. It needs to be done in a planned manner without the need for hospital admission. And that's the key aim about starting a patient on dialysis. It's a cool, calm, collected, elective treatment start, basically. And that's what we want to aim for. So if we briefly take transplant and supportive care away, and we focus more on hemodialysis and peritoneal dialysis, what do we need in place to start? And I think the most important thing is actually we need a prepared patient. We need a patient that has early access to education regarding the modality of renal replacement therapy and also early transplant evaluation. And as far as possible, patients have to determine the treatment they are going to undertake and sort of make a positive choice. And by as far as possible, there are obviously clinical factors that would limit a patient to receiving a certain modality of renal replacement therapy. So for example, some patients won't be able to go onto the transplant list, whether that's due to age, previous malignancy, or severe vascular disease. But also, you know, a patient may not be eligible for peritoneal dialysis because of previous abdominal surgery, ileal conduits, stomas, etc. So the patient has to make a positive choice in the terms of the modality. And also the education around the methods is really important in terms of what options are available to them, but they need to understand why some of the other options aren't available to them. And having education around that is really important. The next step to think about is access. And we talked a little bit about fistulas at the start, but actually the process of forming a fistula can be quite long. We have to think about surgical referral, the actual surgery, allowing for any complications, and then also allowing the fistula to mature. So allowing a fistula to mature can take, you know, about 3 months or so. So actually planning to start dialysis for hemodialysis, requiring a fistula, you need to sort of think 6 months out of your sort of anticipated date of dialysis. And if there are issues with that, issues with access in terms of fistula formation, or the rate of EGFR decline is quicker than you'd anticipated, then a tunneled dialysis line may be appropriate as well, or may be required. And similar thoughts are needed in terms of peritoneal dialysis. We need a PD catheter, whether that's inserted radiologically or surgically. It takes up to 2 weeks after that for it to be sort of safe to use. So these are all thoughts that need to be thought about earlier rather than later. Moving on now to factors that affect the timing of dialysis. And I guess one of the most obvious and maybe more of the clear thoughts is about EGFR. So I'll talk a little bit about that. It's not quite as straightforward as a number. We start dialysis at this EGFR. It tends to be between an EGFR between 5 and 10. But again, it's not quite as straightforward as that. We need to look at that rate of EGFR decline. How quickly is it declining, but also at the age of the patient. Let's say, for example, a 50-year-old started with an EGFR of 30 and was losing 4 or 5 off that every year. They're far more likely to progress to end-stage kidney disease than the similar patient who is 85 years old. So actually, the focus more is on trajectory and not an absolute number, but it tends to be between 5 and 10. The next sort of things to consider are metabolic parameters. Sort of the consequence of having kidneys that aren't working and the metabolic consequences of those. So by that I mean fluid status, hyperkalaemia, chronic metabolic acidosis, and hyperphosphatemia. And we do have ways and means of managing those. So obviously fluid status, diuretics, hyperkalaemia, we can look at some potassium binders, so like calma, pateroma, but also diet. We have bicarbonate for metabolic acidosis. And again, we have phosphate binders for managing the metabolic parameters. And actually, maybe if these metabolic parameters are becoming difficult to control, or the treatments that we're giving aren't working, then actually it would push our dialysis date slightly earlier, more towards that EGFR of 10 than the EGFR of 5, for example. And in Mr. R's case, going back there, actually his potassium was very well controlled without the need for potassium bind. It was all managed with diet. And the last thing, and it's probably the most important thing, and should probably mention first, is the patient. And it's not necessarily all about the numbers. It's actually more about patient symptoms. And I didn't realize that actually patients tolerate their symptoms of CKD differently, whether that's itch, loss of appetite, fatigue. And it depends on a few things. Dr. Frankel asked me just to sort of elaborate more on what this, our gentleman looked like. And, he's a large gentleman, quite a bit of muscle mass. And so, let's go back. And so actually, if the larger men tend to tolerate the symptoms better. And that's why his EGFR was quite on the low side, and we could hold off a little bit with him. But also depends on what's causing your chronic kidney disease. So patients with diabetes and heart failure tend to tolerate these symptoms worse. And as I mentioned, the larger individual tend to tolerate them slightly better. So if we now go back to Mr. R and we look back at his rate of EGFR decline from 2017, we can start to think about where we're plotting things on the map. So he actually first attended in March 17 to the renal team at Charing Cross. There's obviously that period of initial investigation. His immune screen was negative. He had an ultrasound which was NAD, the fact that he had a previous left nephrectomy. He had his first appointment with the pre-dialysis team, so really starting to think about early education for this gentleman. He had early thoughts about access, so he had his AV fistula surgically done in February 2020, and that was sort of coincides-ish with his option for home hemodialysis. And towards the end of 2021, he was actually cleared by the transplant surgeons and by the medics to be placed on the transplant list. So he was placed on the transplant list then. And initially, obviously, as we were investigating him for infective endocarditis, he was temporarily taken off at that point and then put back on. And more recently, he's actually attended a live donor education session in the last couple of weeks or so. His EGFR is still around 5. There's been no sort of further deterioration. He's managing well, but there are plans for him to start dialysis in the next, well, couple of days, really, I believe, sort of next week, as far as I understand. But I think this slide gives a good picture of the process and of the work that goes into preparing a patient for dialysis, all the way back from 2017. And this is not quite accurate because there's a bit too much stuff spread to the right side. There's a bit of a delay, and that's probably because of COVID. So normally you want to push things slightly more to the left, in fact. And this process has basically now allowed Mr. R to commence dialysis in an option that he's chosen, he's educated about in a controlled and an elective manner where he's got appropriate access that's been there for a long time. And that's a good sort of stage through. In terms of his other medical issues, in terms of why he attended Charing Cross, he had an echo which showed no sort of valvular vegetations or anything like that. He remained clinically well, had sort of serial negative blood cultures, and was discharged home. And his eye was actually thought more to be due to a viral conjunctivitis, and Ross spots due to his hypertension, was past hypertension. And that basically is me finished. I mean, if anyone's got any further questions, I'll do my best to answer them. There's a bit more information here in terms of further reading and a few references I use. The Kidney Care UK website is actually really good in terms of around education and educating patients around CKD. And the renal registry reports are also very useful. So that's basically it.
Thank you very much. That was really, really clear. Would you mind going back to the slide with the graph on it? Just to point out.
Yeah,
that
of course.
That starts at 30, so it's pretty low at the very start. And so it's a very gradual decline. You mentioned the difference between men and women, possibly. The other thing is diagnosis, underlying diagnosis. So what was his underlying cause of renal impairment?
So Dr. Frankel, please feel free to interrupt, but he thought to be hypertensive, but also due to the fact that he'd had a left-sided nephrectomy as well. That was thought to be the cause.
Because I mean, I thought with diabetes, as does Dr. Frankel, and I wouldn't be waiting this long because they tend to decline really much more quickly, I think. I don't know if Dr. Frankel wants to say anything about that.
So just to highlight a couple of points about this trajectory. This is a very typical trajectory. I wish more of our patients followed this so predictably. I would like to say that we didn't go into some of the detail about the previous malignancy and nephrectomy. And in fact, he also had a lesion in his remnant kidney that required ablation. So he lost some of that. And there's 2 points I want to make about that. Firstly, when you lose a kidney, you are not going to get end-stage renal failure in your lifetime unless there's something wrong with your other kidney. So he clearly had an additional process besides losing renal mass. And that probably was hypertensive, but he was never biopsied at any point. And then that was aggravated by the fact that he actually had a lesion in his remnant kidney that required radioablation. And the second point that follows on from that, if you look at this graph, and I have to say, Tom, I thought you presented it really beautifully. The whole thing, I was really impressed in terms of you really understanding it from the patient's perspective as well. We would normally shift that transplant bit much more towards the left to try to enable this patient to achieve preemptive transplant, but that was slightly held up. It wasn't slightly held up, it was held up significantly by the fact he had a second malignancy in his remnant kidney. So this would be a typical trajectory, but you would normally move that transplant workup, if they're eligible, right up towards the left, try and get preemptive transplant. Does that help you, Karim, and answer your question?
No, indeed. And also, of course, just after his AVF, we had the lockdown, which of course must have affected things a lot.
And Karim, sorry, it's Jeremy here again. And Andrew, I'm sure this is the patient I looked after because of everything you just said, Andrew. And that last bit on the right, there were many attempts to start him on dialysis, but he was, as you said, and I agree, it was a very nice presentation, Tom. He was asymptomatic, and this is a real challenge. People who have no symptoms, and we tell them they've got bad numbers, GFRs of 7 or 8 or 9, and they don't believe us, and they need to start. And he's a young man, and he was, yes, partly COVID and partly was very reluctant. Once that, so going back to sort of December 2020, when his GFR dropped below 10, but he was very reluctant to ever start in any planned fashion, though he'd accepted his fistula, so he was in a perfect place to have a nice planned start.
I would say, Jeremy, he's a, one of the things I've asked Tom is what he was like, and I think Tom would agree. He's actually been very well and remained well. And you're absolutely right, Jeremy. People don't realise what their numbers mean, and we have a lot of people who want to delay starting because they don't realise how unwell they are. He was on, I was actually quite cool about. He really was very sensible. He knew he was going to start. He'd had his fistula. He wanted to start a particular unit, but you're absolutely right. It sometimes is important that the patient understands what's going on so they can make that decision. I think, Karim, is there a question?
There is, and it's a good one. So another option for if the patient, obviously, once on dialysis, you've got quite a lot of work to come to hospital 3 times a week and so on. And Mel Deeney's asking, why is it so important to start in a planned manner and not as a hospital inpatient? In other words, why not wait till you absolutely have to have it, go on to emergency dialysis, and then move on to the chronic services?
Well, it's not in anyone's interest to adopt that approach. To the patient, it carries enormous risk, because although you're seeing this as a linear decline, many patients decline in a stepwise way. And of course, if you become unwell and you acutely need to start and you come into hospital, someone's going to stick a femoral line into you. They're going to need to dialyze you by a dialysis catheter. And we know that all of those things actually increase your mortality further down. If you actually can start with the idea is to start a preemptive transplant, and then your longevity, your quality of life is so much better. But if you actually start with an AV fistula without the need for a catheter, you actually will have a better outcome than someone who starts with a dialysis catheter. Sometimes we still need to do that. So it's about outcome from the patient's point of view. And medically, you're then putting enormous pressure on the systems because you're managing these patients. They will be managed in hospital, and they carry all the risks of what they could acquire in hospital. And it's not necessary. And if they are going to see this as a huge challenge to their life, let's try and make this going across this barrier of starting dialysis as calm and as smooth as possible for the patient to maintain their quality and what they're doing in their life, so that it disrupts their life as little as possible.
That's really helpful and clear. Can I ask you about diabetes in particular and how this gradient might be a bit different?
So the gradient may not be different. I mean, people with CKD progress usually at a linear rate, but not always. The problem with people with diabetes is that they often experience symptoms of their end-stage renal failure earlier than people without diabetes. So classically, they'll feel more nauseous, more tired. They'll have more problems with potassium. And they may, I've seen us considering starting people at the 10 to 15 range, particularly for potassium issues. So they often do have that less tolerance. And I have to say, unless Jeremy's got any ideas, I don't think we really understand why that is the case.
No.
Okay.
Correct. And to add, I mean, clearly everything Andrew said is of course correct. The only thing I would add is that the diabetics with heavy proteinuria do in general progress much more rapidly, and so a rate of loss of GFR of even sort of 5 mils a minute per year is not uncommon in the proteinuric diabetics, which of course many are, but the heavier your proteinuria, the more likely you are to decline more rapidly. And sadly, we're even in our expert clinics, we sometimes fail to spot that speed of decline in the heavily proteinuric diabetics, and sometimes miss the opportunity to have a planned start, and that's sometimes rather sad for the patient.
Yes, Shivani's got her hand up.
Oh, hi. Yeah, thank you. Thanks for a really interesting talk. Question to Andrew. Can we use SGLT2 inhibitor transplanted patients for diabetes hyperglycemic management?
So Shivani, there's a number of smaller questions in there. First of all, SGLT2 inhibitors, to use them for glycemic management, I think that's what you're trying to tease out. Of course, they have very little glycemic effect once the GFR drops below 45, and it's virtually nothing at 30. So below 30, prescribing an SGLT2 inhibitor will have no effect whatsoever on the HbA1c. However, the cardiorenal protection of these agents does seem to be an entirely separate effect to the glycemic effect, and in all the studies is been found to be present as low as you go, or as low as it's been studied. So in the Credence study, it was down to a GFR of 30. In DAPA-CKD, it was down to 25. And we know from analysis, of retrospective analysis of these studies, it's still there at a GFR of 20. That cardiorenal protection from heart failure and protection from declining kidney function. We don't know when that effect stops, and we need to see more data on it in order to decide how low we can go with SGLT2 inhibitors for cardiorenal protection. For transplant patients, if you're using it for glycemic control, then really it's the same rules. You will have to have a preserved GFR, and many of our patients don't have that. And if you're using it for cardiorenal protection, which of course we'd like to do because many of these patients actually have suboptimal kidney function, there isn't the data that would allow national guidelines to say it's a recommendation. And we really are going to have to wait further studies, but I believe people are using them at the present time.
Okay, so basically in someone with that has a graft with reasonable function, it would be okay to start an SGLT2 inhibitor.
Yeah, with all the normal rules and regulations and advice to the patient. I think as we're using these drugs more, we're learning to be more confident with them, and many of the things that we feared aren't happening. And of course, most of these patients are type 2. Of course, you would not use them in type 1.
Yeah, thanks, Andrew.